Hi, everybody. Thank you for inviting me tonight. I'm Khalid Syed. I'm an orthopedic surgeon. I'm actually one of Dr. Chahal's partners. So I'm going to talk about something a bit different that Dr. Chahal talked about. If he showed you Canada's Wonderland, I'm going to show you the zombie apocalypse. But that's a good thing, as we will come to realize. I'm going to talk about system. So what are the problems in the system of healthcare and where there are opportunities to innovate, ideas that I'm hoping some of you will run with and change things for us, change the world, make wonderful things, as Steve Jobs used to say. So, a lot of you guys innovate in the healthcare spectrum, so you know a lot of this stuff, but just to rehash. So our healthcare system is very complex. It has components, so people who provide care. It has institutions, buildings and things where you go to get care. And it has money. Money runs the thing. And they're all important. So, you talk about the components. These are some of the components, not all. Physicians, nurses, therapists, clerical staff, technologists, administrators who run the thing, pharmacists. You talk about institutions, hospitals, community clinics run by the government, physician offices that they fund themselves, labs, nursing homes, rehab facilities, convalescence facilities, and then the money. Majority of the money in our healthcare system comes from OHIP, which is the Ministry of Health. Anyone know what the yearly spend is by OHIP on healthcare?
Around 50 to 52 billion.
Yeah, exactly. So about 50 billion or so. That's a lot of money. Most of it is wasted, but we'll talk about that. About 13 billion of that goes to physicians. The rest of the 37 billion is infrastructure. Nursing is the biggest healthcare cost of the whole thing, and the hospitals are number 2. Then there's private insurance, so your benefits from your employer. That actually is a very significant part of healthcare spend. Out-of-pocket expenses that patients pay because they have no benefits, and OHIP doesn't cover certain things. Research studies are a small source of funding for healthcare, and then people go for out-of-country treatment. That is a very small portion for the ultra-rich. So what's missing in that? Anyone?
Patient.
Yeah. So the next slide is the patient. So the patient's missing. And it's a common theme. You'll see it over and over again. And that is your opportunity to innovate. The mantra of our healthcare system is that it is patient-centered. The patient is the center of everything we do. But that's not true. And I'll show you how that's not true. It's supposed to be all about the patient. But the patients are lost in the system. It's like someone made an entire facade and forgot to put the centerpiece on the mantle. Like Mona Lisa, and you didn't do the smile. Mona Lisa has a smile, it's not gone. But I'm making a point. Please. So the patient experience should be the center of the healthcare system. But this is what happens in the healthcare system. Again, this is the zombie apocalypse part. So patients are running around for second opinion, third opinion, nth opinion. It's like a recursive function. People are worried about who I'm going to see. If I have a problem, should I see my family doctor? Should I go to Emerge? Wait for 12 hours? Can I access a specialist directly? And these are questions that patients have in their minds. So ultimately, and this is true of our healthcare system, it's fragmented, it's inefficient, it's ineffective essentially, it's expensive, it's wasteful, and it's disorganized. So you see that's, I'm of Indian origin, so that's a road from Calcutta. I've never been there. What do you see? Anyone?
Lots of cars.
Yeah. So if you're driving home, what do you think when you see that?
Traffic. Oh, okay.
Yeah. Anyone else?
Pollution.
Pollution, good. Anything else?
Best time to call my mom.
Good. I'm not going home tonight. Okay, so some see disaster and some see Uber. So all of this mess is really opportunity. And I'm going to talk about how some of those opportunities are in the healthcare system. There's lots of opportunity to innovate and create. You can streamline healthcare delivery and reduce costs, and that will generate profits. There's lots of opportunity for that. You can guide the patient through the process. Patients who are lost in the system, there's opportunity in that. You can improve the patient experience, and we've heard a little bit about how that can be done remotely as well, and that would generate innovation. Healthcare is a vital component of the human psyche. We all want to be healthy, and there's a wealth of opportunity here. So I will highlight some of the ideas in 4 domains: access, cost, convenience, and utility. Access. So wait lists are the norm in our healthcare system. You go to the doctor, you wait in the office. You go to the emerge, you wait in the emerge. You wait for your physiotherapist, you wait for the pharmacist, you wait for everything. So our system of healthcare is fully insured, is universally insured. So there's no cost to you, but it is time. Time is money. You lose money when you wait. So, and it's more than just waiting in the emergency department or the doctor's office. It's many dimensions. So access to the right care. You're waiting for the correct care, not being bounced from doctor to doctor. Nobody can figure out what's going on with you because you have a nerve problem and you went to an orthopedic surgeon. Well, it's not going to help. Access to available care. So you want the test done today that you need today, not 3 months from now. And access to timely care. You need surgery for whatever reason, and the wait list is 2 years. So you're going to wait 2 years to have an operation. You can improve access. And the key there is connecting patients with appropriate facilities and providers. Patients have limited choices for point of care. So you start your care at your family doctor, a walk-in clinic, or an emergency department. There are other options, but they're not available to patients today. And often these don't deal with the patient's issue. They're just the entry point. The patients don't know that. So you can provide different entry points. You can help patients navigate through the system. So you see the right person for their condition, innovation in that. You can provide access to a source with excess capacity. So if there's an empty MRI machine somewhere, you can direct patients to the empty MRI machine, and they can get their test today rather than 2 months from now. There are specialists who have cancellations and empty slots, and other specialists who have 3-4 month-long waiting lists. You can direct patients appropriately. There's innovation in that. So there's huge innovation in terms of access, and you're connecting patients with the right providers and available capacity. Cost. So our system is expensive and is bankrupt. Ontario has no money. It's in debt. In general, there's no money in the system. So we have to make do with less. And the government wants to save money. There are huge wastes of money in the system because of inefficiency. Just a simple example. So you have a knee injury. I'm an orthopedic surgeon. I look after knees, so I'm talking about a knee. You go to your family doctor. The family doctor says, sure, I'm going to send you to a sports medicine specialist, which is also a family doctor. They go to a sports medicine doctor. They say, okay, let's do some physio, get a brace. See the chiro who's in my office. So you go see the chiro, you get your brace. Then the chiro says, well, your feet are kind of flat, maybe you should get an orthotics. You get orthotics, they don't do anything. And finally somebody says, why don't you see an orthopedic surgeon? You go to the orthopedic surgeon, but your knee is better by that time. So they say, well, you don't need surgery. And you go, oh, everybody said I may need surgery, so I want a second opinion. Second opinion says no surgery. So this pathway of care is worth about $3,000 to $4,000 to the system, basically for nothing. So if you could minimize this, you could save the system huge amounts of money. And the government will pay you money out of that $50 billion if you could save them $10 billion. You can reduce unnecessary visits to physicians. So cost of seeing a doctor, depending on who you see, is about $30 to $200 to the system. Going to Emerge and seeing an Emerge physician is $800 to $1,000. So a very simple idea is to redirect visits from Emerge to family physicians or some kind of other facility where the cost goes from $1,000 to $30. System saves money, and you get something out of it. So simple. This has been discussed, I guess, in previous talks, but maybe a live chat system with nurse practitioners on the other side, where patients can access a nurse practitioner and get advice as to where do I go. Simple question: where do I go? What do I need? Simple service. it will save you huge chunks of cash in the system. And then you can go beyond that and looking into smart neural systems like Big Blue or Watson, etc., where you're using big data, huge chunks of data, to determine how to direct patients appropriately, or web-based questions, and many options. Convenience. So patients want access and care when they need it. So they may want it after hours, they want it on the weekends. They don't want to go to an emergency department or a doctor's office to get access to care. So perhaps a system which is a hybrid of Angie's List, eBay, and Uber to match physicians and patients who want care. Similar to the idea of therapia, which is physiotherapy, or your idea with the psychologist. But you could scale that, right? Imagine the scale if you suddenly had the entire medical system at your fingertips. And you would save, you save that mess of $3,000-4,000 and provide access to care in a convenient fashion. And there's a limitation that you cannot touch somebody across the screen. Maybe one day, not today. But that's why we have wearables. With wearable technologies coming into vogue, huge opportunity, And then utility, which is like the fourth domain I was going to talk about. So physicians currently, in terms of technology, are working in the dark ages. 30 to 40% of the time of physicians is spent on documentation, right? Our documentations are electronic, so we're dictating, we're typing, and we use what's called EMR system, electronic medical record systems. They're archaic and unfriendly. This is a great area of need in the medical profession. And if you had a user-friendly, intuitive, and time-efficient EMR system, it will sell like hotcakes. So on the next slide, I'll show you an EMR system that is very commonly used by family physicians. It's like a text thing, right? There's no way to click here. This is like DOS. Most of you don't even know what DOS was. It looks like DOS. So we're working with this, right? If you came up with, some innovative, iMac type deal where everything made sense to everybody, huge opportunity, millions of dollars worth of opportunity. So huge capacity for technology innovation. And healthcare has lagged behind in terms of innovation in technology. So there's tons of room to innovate and create. Last thing I was going to say before the questions is, I'll give you an example. I work at the University Health Center, which is made up of 5 institutions. Princess Margaret's part of it, Toronto West and Toronto General. And this is the largest hospital in the country, in Canada. And it's, I think, the 5th largest hospital in North America. We use an EMR system internally that's run by our own IT department called SINS. The core of that technology is written in COBOL. Like, who writes in COBOL? There's no, MVC. There's no way to scale this thing. They keep patching it with shells. Like, think about it. If you came up with a database management system for hospitals, they'd jump off of COBOL right away. So, huge opportunity. So these are some of the gaps I see in healthcare where innovation in technology can really make a difference. Save money in the system, provide better care to patients, and make profit. Thank you. Sir.
So going back to your first slide when you were showing, well, not your first slide, but one of the early slides showing how the system is composed, and one of the things was institutions, right, which soak up a lot of the dollars.
Yes.
I'd like you to comment on how, and this is probably relevant for a lot of companies, how the risk averseness of these institutions, being very risk averse, they don't facilitate the intake of innovation easily in any area.
Right.
So you can comment on that?
Absolutely. Bodies at rest remain at rest, and bodies in motion continue with uniform motion in the absence of an external force. Second law of Newton. That is how they are. Amazon is killing Best Buy. Best Buy will never try to do what Amazon does, but Amazon's winning. Same idea. They will not hand down their weapons and surrender to technology. Technology basically has to destroy them. That's the only way. Yes, so the institutions have jobs, right? So if technology comes in and you get 10 administrators get fired, of course they're not going to accept technology. But technology will come. The question is, who's going to bring it in?
But from your position, how would you advise sort of a small startup to kind of lead that find a pathway in?
So the pathway is not getting into the institutions. Don't try to fight them. That's not the way to get into the system. The pathway is in creating an innovative product that people want to use. It'll just permeate and multiply. That's the way to get in. If you try to compete with the institutions, they got a lot of money. They got $50 billion, right? You can't fight them. If the pathway is to make something that is so innovative that people have no choice but to use it. And that's how you win. That's how technology wins.
You can look at the situation and sort of see a very technocratic approach, right? Where sort of the external technology drives change, but at the same time, you sort of look at work done by people like Atul Kwame and others, right? I mean, there's some inherent challenges in terms of adoption of best practices. I mean, checklist, right? This book written back.
Sure.
We've got some fundamental issues like that. How do you sort of see, best of breed technology solutions, adoption within healthcare, especially in Canada? How is that sort of compared to some of the other markets that you might?
So there's two kinds of technology innovations, right? So one is how can we implement technology to improve the current system? And that's where the EMR system or database system, etc. So there's lots of areas of improvement. We could talk all night about that. This is a million different things. Just the checklist thing has a huge thing behind it that you could do. And then there's the other one where, we're just going to change the world, like the iPhone did, right? 10 years ago, you didn't know you needed an iPhone. Now you can't live without your smartphone. Google just copied iPhone eventually. But so there's that kind of innovation, right? That would change the world. You can do both. You can certainly do both. So there's a lot of room where technology can improve it could plug into the current system, and that's fine. And there's definitely money in that or innovation in that. But there's the second level where, just disrupt it. Blue ocean. Find a new, realize a market that nobody knew existed. That's where the real innovation, I think, is. That's what's going to change our world. That's the future. Like healthcare at home. It doesn't exist today. So the trick, I think, is to figure out what nobody's thought of, what doesn't exist today, but we all need today. We don't know it.
So just a follow-up question on that piece. When you sort of look at the Canadian market, you said, the zombie company. And what is the other marketplace? So what's the other market that you think has a better system than sort of the Canadian health system?
There is no perfect market. Every place has a problem. The United States has big problems. Access is faster, but it's expensive, so you're not accessible because of money. England has a dual system where there's private and public, so there's a lot of problems with that, and they're running out of money too. NHS has a huge strike thing going on. There is no perfect market. So you're going to invent that. That's the idea.
I guess maybe just following up on that, being around the space I've heard this now for 3 to 5 years. We talked about getting out, away from hospitals, making it more patient-centered, getting out there, all that other stuff. And it's great to talk about. Innovation is going to break it down, but it hasn't, and it won't. And it will. I'm somebody who believes that technology will solve these problems. But I guess is there even more pragmatic answer to this, a more practical answer to there's the institutions that need 3 to 5 years of proof and pudding before they'll implement anything, and that's the reality of the clinical standard. And then there's the innovative world that is making these differences and doing these things. But this world has not been able to penetrate this one for the last 5 or 10 years. And I don't think just saying, do really great things and then it's going to fix everything is there something more practical to square those two together, the clinical thing with the way the innovation world is going right now, beyond just create amazing stuff. So there's lots of amazing stuff created in the city that fights that system, doesn't get implemented, and just faces the reality of bureaucracy and the way that things are today.
Steve Jobs stole the mouse from Xerox, right? So you don't have to come up with the original idea, you just have to steal it. What does Uber do? Connects drivers to passengers. What does eBay do? Connects buyers and sellers. So I think my thought is that the innovation in healthcare that will change things is just going to be a connection. Something that connects the people who need something, people who can provide that. Therapy being one option, one example of that, but you can do it on a much grander scale.
But at the end of the day, those people are still paid by OHIP, paid by the big bureaucratic institution that is there. So how do we, is there any real
sure.
squaring those two together?
So there's a good answer to that. So yes, so in Ontario, if you see a doctor, that doctor cannot charge you for that healthcare provided. OHIP has to pay for it. And so that stifles the payment models. If you see a doctor online, that's not covered by OHIP. So that's also the strength. Because if you see a doctor online, that is not a OHIP-defined service. So you can see somebody through a secured channel, like you talked about, and that's not under OHIP. So, would somebody pay $5 to talk to a doctor about their problem and then carry on with their life, or would they rather spend 2-3 hours in a waiting room before they see the doctor? People will pay $5. People will pay $50 to save 3 hours of their lives, which time equals money. So if you provided, that's a simple example, there's many examples, but there's, just easy access to a physician through a, not Skype, but a chat system or whatever, that by itself, people will pay for it because people value their time. People wait in my waiting room for 2 hours. I bet you they'd pay $50 and forget about the fact that it's free otherwise and get on with their lives if they get an answer.
Yeah, so that's like a private-public blend where the private's being provided more by technology, making the private sector more effective, but the public still is there, so I guess it's going to have to be split those two.
Correct. So that's hard because the public system will fight you tooth and nail.
Like Uber disrupted the tax industry, but now they work with the industry and it's making it more effective, making the industry change. I guess
So what happened was the taxi industry understood that Uber's here to stay.
Yeah.
They can't kill it. They protested, they hung off the cars, they tried to break their windows. Nothing changed.
So being a doctor, you're saying enough technology being used by people outside of the system will make doctors finally come around to it and then make them change the system.
Correct. That's my point. You build it, absolutely. If you build it, they will come. I like cliches.
I just got a comment based on that. I think changing the behavior of doctors is very, very important. And I think healthcare practitioners in general, I think when it comes to changing behavior, it's a huge challenge. These market machines are a challenge, a cultural challenge. And I think it's got to make sense of all these things. You're not going to do that because it's very hard. Doctors in Ontario or Canada are so used to working in this good way. There's really a lack of balance in central frequency change. And let's just really better relations or really better
Well, so right now, doctors are being squeezed by the province, as most of you have read in the newspapers, right? So they're cutting their fees, they're cutting their whatever, blah, blah, blah. But this provides an extra, right? This is out of OHIP. So if you, just like your psychologist, after hours work, because that is beyond what they would normally make, that may be enough. And there are other models that you don't need to have doctors on the other side. You can have nurse practitioners. You could have a system where specialist nurse practitioners look after MSK problems, neurology problems, blah, 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 and they'll run your system, and there is no doctor involved. You can have a navigation system. There was one here earlier. There's lots of opportunity, and you got to sort of figure out how to do it. For sure, doctors are hard to change their behavior. It's a very hard thing to do, for sure. But they'll do it, right? If it becomes the norm, they'll do it. And my parents didn't use computers. They do now, because they can't pay their bill otherwise. So
just to be proactive, should we be looking at ways to then disintermediate physicians? If they're part of the problem, they're fixed in the way that they're reimbursed, in the way that they've practiced for all these years. Let's get them out of the middle, except for areas where you absolutely need them. So you can't replace a surgeon. robots are getting there, but still not
Sure.
really. But should we look at where their value really lies and where you can really replace them with
Absolutely.
technology?
Absolutely. That's absolutely correct. That's what what I alluded to. You don't need physicians to run the program that hybrid system I talked about, where you could have like a bidding system where people get care or advice online. You don't need physicians for that. You just need well-trained nurse practitioners. Sure.
So just
Sorry.
to go back to the notion of making stuff practical and one of the earlier questions, like I really believe, money is where the crack has to happen for real change to happen. But we can't, that big pool of $50 billion, lots of people have their mittens, attached to that. So when you talk about pragmatic, I think creating a hole in that bucket called, okay, if we have to spend that, and this maybe is a policy change, if we have to spend $50 billion annually, we collectively force the folks who create the policy and have to say a certain portion of it increasingly has to go to innovation spend. So it's still in the system, but the people who receive it, they're incentivized to spend it on tangible innovations, where they're showing innovation, not talking it.
There are innovation grants from healthcare, a significant amount.
But I'm not meaning grants, I mean like from that big 50 billion.
Right.
Like the annual spend, that part of the policy framework is whoever is receiving it must show real innovation spend. So.
Sure. So the converse of that is that if you could show that you could save 1 billion out of that 50 billion, you're sold. Right? You're in with the institution. You're in with the crowd. So if you can make something, innovate, create, that then shows that there is actual dollar savings, the government will love you. They want that, right? They want that now. If you made something that you can show saves money, they'll give you money for grants. They'll fund your company to innovate. So you got to take the first step. If you take the first step, there are roads inways into the institutions. But if you just showed up and said, this is all wrong and I'm going to do something different, they'll shoot you. So, someone had a question. Sorry.
Yeah, I've seen two kind of different approaches to solving the problem. There's the distributed approach, like the different companies here. Then there's like IBM Watson, which is more of a grand systematic approach. Which do you see being more advantageous, and how do you bridge that gap, if so at all?
That's a very good question. So I was walking around looking at the different exhibits today, and each idea is excellent. But if you put it all together, it'd be that amalgamation, that system I just talked about. Because someone here knows how to find access to clinics that have empty space, someone else is measuring outcomes. If you put it all together, it'd be incredible. So yes, I think an integrated system is the key, but you got to start somewhere. What you've seen in tech world over and over again is something starts with something. eBay was founded to sell Pez dispensers, right? And now it sells a lot of stuff. Same idea. So you got to start somewhere. I suspect what would happen is if you have like 100 companies doing something, everybody's doing something different. One person, one company, or a few group of companies, emerge out of that as the leaders, and the other ones just kind of die out. Sorry, and then they have it's natural selection, right? Survival of the fittest. So whoever has not necessarily just the best product, but also the best marketing, the best outreach, the best acceptance, which you may not be able to control, will survive. So it has to start somewhere. So I think every company who has a good idea should move forward, and they'll grow. Facebook bought all sorts of stuff, but it started off as Facebook.
Do you think that the fact that it's expensive to get that data, in some cases, in the States to get FDA clearance on some of your products, do you think that that's why the healthcare system has sort of missed out on the tech revolution?
I think so. So for example, in the OR, We use machine, like for arthroscopy, where you put a camera into a joint, which Dr. Chahal was showing you, right? So there's a computer that is basically a PC that runs the software to show you the video on the screen. So that runs on a Pentium 3. Have you seen a Pentium 3, like ever? Because the computer has to be cleared by Health Canada, the chip, the PCPU has to be cleared by Health Canada and FDA. They can't put it in the machine if it's not cleared. It takes 4 years to clear. Your technology cycle is 1.5 years, 18 months, right? So the thing is double outdated by the time it actually ends up in a machine. So I think that's absolutely correct. The red tape and the barriers that the institutions create are counterproductive. That's why we are behind in technology. It's by design.
Is it realistic to think that that will change, or is it just move on, work around that constraint?
So I think work around that constraint is a better option than trying to change that, because that's well ingrained in the system. I think one day it will, but today I would work around it.
Thank you so much.
Thank you.